Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, my name is Sarah Tellini. I'm a breast medical oncologist at Dana-Farber Cancer Institute and chief of our breast oncology program here. I'd like to welcome you to our program today on determining the risk of recurrence for patients who have hormone receptor positive, HER2 negative early breast cancer who did not undergo an axillary dissection. And I'm really excited today to be joined by two of my very esteemed colleagues. So I think we're going to have a great discussion. Dr. Elizabeth Mittendorf, who is the Rob and Karen Hale Distinguished Chair in Surgical Oncology and Vice Chair of Research in the Department of Surgery at the Brigham and Women's Hospital and co-leader of the breast program at the Dana-Farber Harvard Cancer Center and professor of surgery at Harvard Medical School, and actually our future ASCO president-elect. So really excited to have Beth with us today. And Dr. Leah Portnow, who is a staff radiologist at the Brigham and Women's Hospital and the fellowship program director in the Division of Breast Imaging and assistant professor of radiology at Harvard Medical School. So thank you both for joining us today. I'm looking forward to our discussion.
Thanks, Sarah. It's good to be here.
Thank you for having me.
So I think today really our focus is to think about how to think about lymph node assessment in patients who have early stage hormone receptor positive disease. This space has really evolved, I think, very dramatically over just even the last year or two. But in the medical oncology space, our systemic therapy options have also really evolved quite a bit over the last couple of years, which also makes it critical for us to sometimes understand the degree of nodal involvement in patients. And so I think just taking a step back at why would we really need to understand how many lymph nodes are involved in a patient and how would that impact any treatment decisions that we're making? I think first off, this information is important from a prognostic standpoint. So understanding how many lymph nodes someone has certainly gives us a better idea of what that patient's risk of recurrence is. We have lots of data suggesting that if you, for example, have 4 or more lymph nodes involved and have an early hormone receptor positive breast cancer, your risk of recurrence is probably in the 30 to 40% range. Whereas if you have fewer lymph nodes involved, so for example, 1 to 3 positive nodes, your risk of recurrence is more in the 20% range compared to probably 5 to 10% in someone who does not have any nodal involvement. So clearly, this is very much important prognostic information. But we also have a lot of other prognostic indicators outside of just lymph node status. I think we've become a little bit more evolved in our thinking and understand that really the biology of the disease is actually quite critical in understanding someone's risk of recurrence. So I think there are lots of features that we take into consideration as a whole when making a decision about what someone's risk of recurrence is. Again, it's not just the number of lymph nodes involved, but also these other factors. But despite having lots of different things to think about, when we are making decisions about new therapies, including CDK4/6 inhibitors, sometimes lymph node status actually does really come into play simply because the data that we have for use of either ribociclib or abemaciclib is dependent on degree of nodal involvement. So, for example, in the Monarch E trial that was done, it specifically looked at abemaciclib in patients who had very high risk ER-positive disease. And how they defined that was that someone had to have 4 or more lymph nodes involved, or if they had 1 to 3 lymph nodes involved, they had to have a tumor over 5 centimeters, or it had to be high grade, or it had to have a high proliferation score. So it did mean that you needed to understand degree of nodal involvement to figure out if they were a candidate for abemaciclib. With ribociclib, though, things have changed because the indication for ribociclib is a bit broader. So you could be a candidate for ribociclib if you had any number of lymph nodes involved, meaning 1 or more, And you didn't have to have an additional high risk feature. So you just had to have nodal involvement, period. We didn't care how many nodes there were. Or if you didn't have lymph node involvement, so you had a node negative cancer, you had to have a tumor between 2 to 5 centimeters that had an additional high risk feature. So it had to be high grade or have be intermediate grade with a high genomic assay or a high proliferation score. So this is coming up a lot when we start to think about, who's an appropriate candidate for which treatments. As so sometimes when I meet a patient, I'm trying to predict whether or not they could have nodal involvement. And that, for example, could influence the conversations we have with our surgeons about whether or not they may need to have nodal assessment or not. And so, Leah, this is where we come to you, and we're trying to figure out if someone may have nodal involvement. And one question that I often have is, let's say I have a patient, for example, that had an MRI and I didn't see any enlarged lymph nodes. Is that adequate for me to feel pretty confident that they're not likely to have nodal involvement? Would it be better to get an ultrasound? How do you think about what the right imaging tool is to understand if there are lymph nodes that may be involved?
Yeah, so MRI provides a wider field of view, so it can include levels 1 through 3 axillary lymph nodes, include the supraclavicular nodes as well. Um, and so overall, since the field of view is wider, it tends to have a better ability to count and deduce how many lymph nodes may be involved. However, there are some limitations with MRI, mainly due to potentially patient positioning. Also, there could be pulsation artifact from the heart, so that may limit field of view in the axilla in particular, as well as certain fat saturation artifacts. Um, and also, if we're talking about axillary lymph nodes that may just be kind of on the early stages, they still have metastasis, but they're not necessarily fatty hyla replaced. Um, this may be more difficult to detect with MRI. So ultrasound is actually the key modality of choice because it really provides excellent evaluation of morphology of the lymph nodes, particularly with regards to cortical thickness. Cortical thickness greater than 3 millimeters is essentially our cutoff, and it can be more specific if there's focal cortical thickness or bulging. And then our suspicion level rises with the loss of fatty hilum, uh, round shape, or non-hilar Doppler flow.
No, thanks a lot, Leah, because I think this, often comes up in clinic when maybe someone has had an MRI but didn't have a dedicated axillary ultrasound, and we think, well, do they really need one? It seems to look okay, but it does seem to suggest that you do like getting that axillary ultrasound because it is a better modality for assessing nodes. So Beth, then I often come to you when I have a patient who, um, well, I come to you with questions because I know now things are really evolving in terms of who may even need a sentinel node biopsy at all. And so particularly patients who have really small cancers that are hormone receptor positive, there is some evolving data to suggest that we may not even need to do nodal evaluation. And so can you help us think about this and how you make a decision about who needs a sentinel node biopsy and who does not?
Sure. So uh, I I suspect I'm the oldest one on this call, and I actually remember the days when I was in training that every woman with breast cancer got an axillary lymph node dissection, and of course we evolved to the sentinel lymph node biopsy procedure, reserving the lymph node dissection for those who were sentinel node positive. We then evolved to identify women who may have low volume disease identified by sentinel lymph node biopsy, 1 or 2 positive nodes, in whom we didn't need to do a full dissection. So that's Z11 is the trial that I'm thinking of. There are several others. And that led to the question of, well, are there patients that we may not need to do any nodal evaluation at all? And so, as a caveat, I think most of us are very comfortable with omission of sentinel node biopsy in our patients who are 70 and older, and that's the Choosing Wisely campaign. But there have been a number of trials now that have started to report out looking at that question in women who are under 70. And the two that I'm thinking of are the Sound trial and Ensema. So Sound was published in around November of 23, It looked at women with T1 N0, and to Dr. Portnow's point, they had to be N0, meaning no palpable adenopathy and either a normal axillary ultrasound, or if there was an abnormal ultrasound, a negative biopsy. And it said, okay, half of you are going to have the sentinel node biopsy, half of you are not. And in the group that had the sentinel node biopsy, the likelihood of finding a positive node was about 14%. But importantly, what the trial was looking at was, is there any difference in the distant disease-free survival between those two approaches? And the answer was no. I think another really important point of the trial is that for patients who are on the study, meaning their actually ultrasound did not demonstrate anything suspicious in Dr. Portnow's hands, only 0.6% had 4 or more positive nodes identified. Really important, the data that was presented at the San Antonio Breast Cancer Symposium just about 6 weeks ago now was looking at the Encima trial, which it's a complicated study with 2 randomizations, but the first randomization is the one that's of interest for this conversation. And it looked much like the Sound trial in that it randomized patients to either the sentinel node or not. And again, remarkably consistent data. It was about 13% of patients who, in fact, had a positive sentinel node, a very similar population. They also had the negative axillary ultrasound, and no difference in invasive disease-free survival. Now, I didn't go into the weeds of those 2 trials, but they were also consistent, and I think helping us identify the population we might feel comfortable omitting sentinel node biopsy, specifically hormone receptor positive, HER2 negative, which is what we're discussing today, tumors that are T1, so less than 2 centimeters in size, and then grade 1 to 2. And I also think that most people have interpreted the data to suggest that it should be limited to women who are postmenopausal.
Oh, thanks, Beth. That's really helpful. So it sounds like, now I know in clinic I sometimes come to discuss with you if we do have these smaller, T1 tumors, and we have gotten that X-ray ultrasound that looks negative, and they didn't have a high grade cancer or have LVI or maybe have a lobular cancer, so don't seem to have features where we may want a sentinel node. It does seem like this is a movement, particularly in the postmenopausal patients. And so we may not get nodal information in those particular patients as things evolve. But you mentioned, kind of going to the other extreme. It started out, when I was a fellow, most people were all getting axillary dissections. And so, how do you think about the other extreme? We talked about who doesn't need any nodal evaluation, but then who really now does need an axillary dissection from a surgical standpoint, omitting the thought about needing the information for systemic treatment.
Yeah, so the clear indication for needing an axillary node dissection would be a patient who receives preoperative systemic therapy and at the completion of that still has palpable disease. For the patient who gets preoperative systemic therapy, no palpable disease, so you do the sentinel node biopsy, but that sentinel node is found to be positive, they'll require an axillary lymph node dissection. But I'm going to contend with the implementation of Sound and Encima, if we start doing routine axillary ultrasounds, we're going to find hormone receptor positive, HER2 negative patients who are positive. And then we're going to have patients with clinical T1C, T2, small T2s, N1s that we're going to do upfront surgery for, that you're not going to give neoadjuvant chemotherapy because maybe they'll have a low genomic risk score and don't even need chemotherapy. And that's becoming a real question for surgeons. Can we treat these patients as we would Z11 or amaurosis if they have low volumes, only 1 or 2 positive nodes, or should they all get a lymph node dissection? There was a clinical trial that was in development through the NCTN to address this question. It's not through the system at this point, it's not open. So in our practice, we've kind of decided that for these hormone receptor positive, HER2 negative that are undergoing upfront surgery, if they have palpable adenopathy, we'll do a lymph node dissection. So again, after neoadjuvant, for continuously or patients who are persistently node positive, and for these hormone receptor positive, HER2 negative with a palpable node that is found to be FNA or core biopsy positive, upfront surgery.
I think that's really helpful. I think most of the people who are getting neoadjuvant therapy often have a lot of disease because we're trying to, potentially downstage them, or they have a high genomic assay, so are often more high risk. And so in that case, from a systemic therapy standpoint, for example, we may not actually need that information to make a decision because most of those patients generally are higher risk. But in the upfront surgery patients, I think this is where we get into the conundrum a lot more about whether it comes up certainly at our tumor boards periodically about should we take someone to get an axillary dissection simply to have information about degree of nodal involvement. I would think that is happening less and less as time goes on, particularly since the ribociclib approval, since it's a lot broader. But I thought maybe we could put it into context of a case, so we could think through these questions that do come up for us in clinic. So this is an example of a 48-year-old woman who had presented with a 3 centimeter abnormality on her mammogram. She had a biopsy of that abnormality, and it came back as an intermediate grade invasive ductal carcinoma that was strongly ER/PR positive and HER2 negative. In this case, she did have an X-ray ultrasound, thanks to Leah, and did see that there was an abnormal lymph node that was there. And so that lymph node was uh, biopsied and did have malignant cells. Um, so in this case, where this patient presented with a 3 centimeter tumor up front that was intermediate grade, it's probably someone we would take to upfront surgery normally. So, did we actually need to do an axillary ultrasound? Like Beth, would you want that information before you've taken someone to surgery?
Yeah, you always choose the straightforward, easy cases for these discussions. So, this case is super interesting because I think there are so many different ways you could think about it. So, she has now, through the workup that was done, clinical T2N1 disease. So, we found that N1 disease on actually ultrasound. I'm presuming that she did not have palpable adenopathy.
No.
So you mentioned that we probably do upfront surgery, although there are plenty of institutions where they've interpreted the responder data to suggest any premenopausal patient, and I guess I'm assuming she's still premenopausal at age 48. She may not be. Would benefit from chemo. So there are institutions who would give preoperative systemic therapy to this patient. You're right. In our practice, we probably wouldn't. And this is that situation I was just talking about where if I hadn't had that actually ultrasound, I would have done a sentinel lymph node biopsy, thinking about Z11 as an example. And if she only had one or two positive nodes, I would not do a full dissection. So in our practice, I mentioned that if they're palpable and positive, we would do the lymph node dissection. But we as a group have come up with what we call SOP standard operating procedure, where if it's only found on imaging, we will do the sentinel lymph node biopsy and only if two or three or more are positive. Now the tricky question is, can I get Leah to help me localize that one that they found to be FNA positive so I make sure that I get it out surgically? And for that, we do use, sometimes we use radioactive seeds to localize them. So this really is a great example of a case that can be treated well multiple different ways, but really requires the multidisciplinary team to think about it.
Well, that's very helpful. And Leah, from your perspective, when you have someone who gets an X-ray ultrasound and didn't have a palpable abnormality in the axilla, and you do see this abnormal lymph node, um, sometimes they come back negative. So, let's say you did that ultrasound and it looked suspicious on the ultrasound, but then you FNA'd and it's negative. And so this always perplexes me and I get a little bit worried. Um, how worried should I be? Do you think that how accurate was that FNA in helping us determine if that lymph node is really involved?
Sure. So yeah, it's kind of interesting. The literature provides a pretty broad range of FNA sensitivity percent. Core needle biopsies, where we take a sample core tissue of the actual lymph node, tends to be a lot higher in sensitivity, and so there has been some transition from radiologists to perform core needle biopsies of the axillary lymph nodes, so far as they deem safety parameters in terms of technical feasibility. But this also requires a multidisciplinary approach. If we stick with our FNA, really good to have a great cytopathologist by our side in order to work with them and establish parameters. What I appreciate from our pathology colleagues is they often will let us know negative for malignancy and specifically note that they see lymphocytes versus a non-diagnostic sample, which does occur rarely. But when that happens, we tend to discuss with our colleagues, particularly you, Beth, regarding whether we further further imaging and or sampling of the node, or in some cases, if we really feel like it's abnormal, which I think I've had one in recent memory, but not too many, and we would proceed to a core if we started with an FNA first. So different ways to consider that, but very institution dependent as well.
Oh, that's certainly helpful. In this case, she did end up having a positive FNA. So, Beth, let's say you took her to surgery, and you did a lympectomy and a sentinel node biopsy, and she had a 3.7 centimeter intermediate grade invasive ductal carcinoma, and 2 out of 2 lymph nodes were positive. What are you going to do now? Do you recommend a dissection in this case?
So this is a difficult one with the 2 out of 2 sentinel nodes. I would probably be lamenting that I hadn't found 3 or 4 sentinel nodes in this patient. So there are nomograms available from both Memorial Sloan Kettering and MD Anderson that you could put into the patient's data into. With those numbers, those nomograms are going to suggest there's at least a 50% chance of finding additional nodal disease. So this is one where you said earlier that there's not that many patients that were doing lymph node dissections to confirm the extent or the number of nodes, and I think that's a true statement. I think you threaded the needle and found the one example where we might actually want to do that, because I anticipate, as much as you may want to know it as a medical oncologist, and please tell us if you do, but I think the radiation oncologist may also want to know the total extent of nodal burden for this patient. So this is one with that risk of additional positive sentinel, or excuse me, axillary nodes. I would consider the lymph node dissection in her.
Okay. Well, that's helpful. I'll say from a systemic therapy standpoint, um, I also try to thread the needle a little bit with this case, in a way that she wasn't clearly a candidate for abemaciclib, in a sense that she had, if you only have 2 lymph nodes involved, you had 1 to 3 positive nodes. She wasn't high grade, and she didn't have a tumor over 5 centimeters. So she didn't technically meet monarchy eligibility. And so prior to the availability of ribociclib, we would have had a discussion about whether or not we would have wanted that dissection or not. Sometimes I think we would do what Beth was suggesting and try to predict, if this patient's at high enough risk that they probably had additional nodes without having that axillary nodal information. But now, with the availability of ribociclib, you don't even need to think about that, because now we have enough data to suggest that even if you have any degree of nodal involvement, you're a candidate for a CDK4/6 inhibitor. And so in this case, with 2 out of 2 nodes, we already know she met, eligibility for needing a CDK4/6. But from a radiation oncology perspective, I would guess they would want this information.
Sarah, can I ask you a question though? Because we focused on how the nodal disease and the extent of nodal disease may inform your recommendations around CDK4/6 inhibitors, but we haven't talked about chemotherapy. And as I kind of alluded to, there are a lot of institutions that maybe wouldn't even send off the genomic assay because they're premenopausal, they're node positive. The RX bonded data suggests that those patients have absolute benefit. I know we, of course, have thought about that data suggesting maybe it just means that they need something, and maybe it's ovarian suppression and an aromatase inhibitor. So as you're thinking about that, does the extent of nodal disease matter to you?
But you really wanted to make this even more complicated. I was trying to fit full discussion.
It's going to make it tough for you.
So I think you actually bring up a really, important point here, which is you're right that, there are some institutions that would say node positive cancer in a premenopausal patient. We interpret our exponder to suggest that everyone benefits from chemotherapy in this setting. So just get chemo and you don't need a genomic assay score. Our group, I think, feels a little bit differently, because I think we wonder if what we're seeing in our exponder for chemo benefit in premenopausal patients, irrespective of genomic assay score, is really simply because the chemo in premenopausal patients is inducing, ovarian function suppression, in which case then they're getting that benefit. And so it may not be the cytotoxic effects of chemotherapy that they're benefiting from, but rather simply the fact that the chemo turned off their ovaries. And at that time, most patients weren't getting ovarian suppression. And so was a toxic way to turn off their ovaries and probably not the right way to do it. But we have an ongoing trial, the offset trial, that is actually trying to prospectively evaluate this question, really randomizing patients to get, ovarian suppression with endocrine therapy and potentially CDK4/6 inhibitor per physician's choice, or to get chemo followed by that. And so that will help us address it, but will probably take a decade to get that answer. So I don't think we're going to have that answer in the near term. And so for now, what I would have done in this case is I would have wanted a genomic assay. If the genomic assay was high, then one would say she needs chemotherapy. If it's kind of on the borderline, in that intermediate zone, I think many of us would think about ovarian suppression and endocrine therapy and a CDK4/6 inhibitor, and potentially omit chemo. The challenge here, though, to make it more complex, is if she did have a dissection and had more nodes involved, she would then fall outside of our exponder. And so if she had four or more positive nodes, one would argue everyone needs chemo because we have no data to omit chemotherapy in anyone with four or more positive nodes because we've never tested it. And so there could be some physicians who would come to the surgeon and say, I need the dissection. If she had a lower genomic assay score because I want to know if I should give chemo. I guess I've sort of felt that it's probably more biology, than simply degree of nodal involvement. So I haven't pushed for that in that case, but I think you're right. You're going to get different opinions here from different people.
Yeah, I was just gonna say that, and I don't think they'll ever, well, maybe I'd be proven wrong, but I don't anticipate an appetite at like the NCTN level to do a trial to repeat our exponder for 4 more positive nodes.
Yeah, it's definitely something under discussion because you're right that I think we've all wanted that to happen, but it's pretty complicated to happen because you're right. We don't even know for most people if they have four or more positive nodes anymore, and it becomes a little bit complicated. So I think you're right. I think it's gonna be hard to do.
I think you could also contend that if we did our exponder over again, now with CDK4/6 inhibitors, we might get a different result there. So
Yeah, I very much agree if that uniformly people did get CDK4/6, it may be different. So, I think we've made this very simple for everyone. I think it just shows how truly complex, these decisions are, and I think that's why I'm so grateful to have my multidisciplinary colleagues in clinic because this is not something any one of us alone, makes decisions about in a silo. It really does take a discussion and, including with our radiation oncologist to make decisions about what to do with lymph node evaluation. So really important, Beth.
So I was just going to add in one thing. I think this really emphasizes where we are with breast, which is really exciting, right? It's being able to very much personalize a patient's care. And it has been demonstrated that it requires all the disciplines. And so I think individual practices have an opportunity as multidisciplinary colleagues to think together on how they want to manage these patients and when they'll get ultrasounds and not. So, kind of a fun time actually to think about how to better care for our patients.
Very well said. I think you're totally right. Definitely personalized care, and that's why these individual discussions about our patients are really so critical. But thank you. I will say it was a fun discussion, and it really was good to bring up all these challenging areas. And thank you to our audience for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation. Thank you so much.